Hello, it's a pleasure to be providing this next update on COVID-19 Therapeutics, the July 2021 edition. It's only been a little more than a month since our last clinical update, yet there's been an enormous amount of new information, which I'll be sharing with you today. These are my disclosures. These are the topics I propose to cover. There's a new RNA-dependent RNA polymerase inhibitor, AT527. There are new data on monoclonal antibodies, including casirivimab and imdivimab, as well as the novel monoclonal antibody sotrovimab. There are additional data on the use of COVID-19 convalescent plasma from the REMAP-CAP study, and again from REMAP-CAP, updated information on immune modulator therapies, including tocilizumab, sarilumab, and anakinra, as well as another trial on tofacitinib, one of the JAK inhibitors. And then I'll provide a brief update on ivermectin. So let's talk first about AT527. This is an orally bioavailable prodrug of the guanidine analog RNA-dependent RNA polymerase inhibitor AT9010. It inhibits hepatitis C virus and a variety of human coronaviruses. And as you can see in this table here, it has submicromolar EC50s against SARS-CoV-2 when tested in human epithelial lung cells, as seen here at the bottom of the slide. Interim results from the phase 2 trial of AT527 in hospitalized patients with mild to moderate COVID-19 have recently been released. This study randomized participants to either 550 milligrams twice daily of AT527 or placebo. And the interim analysis was performed on the first 70 participants, from whom data were valuable on 62. At day 2, patients receiving AT527 experienced a 0.7 log or greater mean reduction from baseline in the virus load as compared to placebo. By day 14, approximately 47% of patients in the AT527 arm and only 22% in the placebo arm had achieved an undetectable RNA or target not detected. AT527 was generally safe and well tolerated with no drug-related serious adverse events, and additional phase 2 and phase 3 trials are ongoing. Well, let's talk about new information relating to monoclonal antibodies for SARS-CoV-2. The recovery group conducted a trial of the combination of casirivimab and imdevimab, two monoclonal antibodies with neutralizing activity, which together are known as REGEN-COV or CoV. This was a randomized controlled open label platform study in hospitalized patients with COVID-19 that included an arm with these antibodies. The primary outcome was the 28-day mortality assessed first among patients without detectable antibodies to SARS-CoV-2 at randomization, the seronegative group, and then as well in the overall population. There were just under 10,000 participants who were randomized to receive either a REGEN-CoV of 4 grams of each antibody or a standard of care. Approximately a third of these participants were seronegative at enrollment. A little more than half were seropositive enrollment, and about 15% had unknown serostatus. This slide shows the primary results. As you can see in the Kaplan-Meier curves on the left, focusing on those who were seronegative at entry, this pair of curves at the top shows how mortality was significantly greater in those who received usual care compared to those who received the combination antibody. By comparison, among those who were seropositive at randomization, there was no difference, showing no benefit of the antibody in these hospitalized patients. Looking at the relative risk, you can see that mortality at 28 days was reduced by 20% in those who received REGEN-CoV compared to usual care. There was also a greater likelihood of being discharged from the hospital within 28 days, as well as a reduction in the risk of progression to invasive mechanical ventilation or death. All of these around the same magnitude of effect, about 15 to 20%. And then there were also benefits in terms of a reduction in the need for high flow oxygen or non-invasive ventilation, and as I mentioned, in reduction in the need for invasive mechanical ventilation as well. Looking at primary and secondary outcomes by baseline antibody status, we see here again the 20% reduction in death among those who were seronegative, but no benefit in the seropositives or in the participants with unknown antibody status. And if you took all of the participants together, there was a more modest benefit that failed to achieve statistical significance. So it's really only in those people who have not made their own antibodies that providing additional antibody therapy is beneficial. And we see that as well in the discharge alive from hospital and the progression to mechanical ventilation. Now, sotrovimab is a newer monoclonal antibody that has more recently been made available through an expanded use authorization. This is an engineered human monoclonal antibody that neutralizes SARS-CoV-2 and several other SARS-CoV coronaviruses. It was isolated from a survivor of SARS, the original SARS, and was initially known as VIR-7831 because it was first developed by Vir and then licensed by GSK. This antibody retains activity against the alpha, beta, gamma, and what used to be known as the epsilon variants of SARS-CoV-2. It also contains the LS modification in the Fc domain that prolongs the half-life of the antibody so that it could be administered in a prophylactic setting only every several months. The COMET ICE study was a phase 3 trial of sotrovimab. This was a randomized, double-blind, placebo-controlled trial in which the participants who were randomized to the antibody arm received a single 500 milligram infusion of the antibody or a blinded control. These were high-risk outpatients with symptomatic COVID-19. So in contrast to the study we just spoke about, these were outpatients, not hospitalized patients. The primary endpoint was the proportion of patients with hospitalization for more than 24 hours or death due to any cause through day 29. Enrollment was halted in March after a planned interim analysis showed the benefit of sotrovimab. Here you can see, although there were approximately 1,000 participants enrolled, this analysis was based on the 600 or so participants who had reached day 29. You can see that there are more people hospitalized than in the placebo group than in the sotrovimab group. There was only a single death, and that was in the placebo group. And when you do the statistics on this, there was an 85% reduction in the risk of progression to hospitalization or death among those who received sotrovimab compared to placebo. And this was highly statistically significant, hence the recommendation from the Safety Monitoring Committee to halt that study and the subsequent authorization for emergency use of sotrovimab. Additional trials are planned and ongoing to look at the use of this antibody in other settings, and we await those results. Well, let's talk briefly now about COVID-19 convalescent plasma, or CCP. The REMAP-CAP group which has been doing this large adaptive platform trial in patients who are critically ill with COVID-19, had one component of the trial known as the immunoglobulin domain, in which participants might be randomized to CCP or control, and you can see the numbers there. As in other domains of REMAP-CAP, the primary endpoint was days alive or free of ICU-based support through day 21. And the primary analysis was a Bayesian cumulative logistic model with predefined criteria for superiority or futility. And as we've seen in so many studies of CCP, there was really no benefit at all. Here you can see the Kaplan-Meier curve at the top, showing the cumulative proportion of participants having days free from organ support. In this case, the lower the curve, the better, but these curves are nearly superimposable. In the bottom part of the graph, you see the distribution of outcomes by proportion of participants having different degrees of outcome as far as days free of organ support, and there is really no difference in that distribution. So once again, yet another trial of convalescent plasma showing no benefit, although to be fair, these were critically ill people, so people receiving either high flow, non-invasive ventilation, or were intubated at the time of enrollment. This slide looks at the dichotomous primary and secondary endpoints, and you can see that regardless of the particular endpoint, there is really no evidence of benefit for CCP in this patient population. Well, there is good news with immune modulation therapies, and just to remind you that in looking at the inhibitors of the IL-6 receptor axis, that IL-6 acts through signal transduction to initiate the inflammatory storm, and that by blocking IL-6 receptors, you can block that signal transduction and hopefully calm the inflammation. There have been numerous studies of tocilizumab with varying results, but the recovery trial, which we reported several months ago, and which showed evidence of a benefit, as did the REMAP-CAP trial, was really the first report from REMAP-CAP that demonstrated a survival advantage in patients who received tocilizumab and led to its emergency use authorization in the United States and recommendation for its use in other countries. So REMAP-CAP has now presented the final results of their immune modulation domain. Again, as we just discussed for the CCP trial, this was an open label randomized adaptive platform trial in patients critically ill with COVID-19. Participants were randomized to tocilizumab, sarilumab, anakinra, or standard of care. When we first talked about this trial, only about 350 participants had received tocilizumab, and only about 45 had received sarilumab. And so here you can see that there are about 2.5 times more people who received tocilizumab and nearly 10 times more sarilumab. And then the anakinra results are new as well. The primary endpoint, once again, was days alive or free of ICU-based support through day 21. And once again, the primary analysis was based on a Bayesian cumulative logistic model with predefined criteria for superiority or futility. An important point here is that after the results of November 2020 showed that tocilizumab was beneficial, enrollment to the standard of care arm was halted so that the subsequent enrollees were really being compared. First of all, we're being randomized only between tocilizumab and sarilumab or anakinra, and we're being compared to the non-contemporaneous standard of care arm. And the primary analysis here was a demonstration of equivalence of sarilumab and tocilizumab. What you can see is that both tocilizumab and sarilumab had an odds ratio of about 1.5 compared to control for providing benefit, whereas anakinra had an odds ratio of 1, so no benefit. And then when compared to each other, there was an 85% likelihood that tocilizumab and sarilumab were in fact equivalent. At the time of the interim analysis, that number was 92%. And you can see that there's 99.9% superiority to control, almost actually 99.8% superiority to control for tocilizumab and sarilumab. That's the probability that they are superior in this Bayesian approach to the analysis, whereas anakinra had only a 0.02% likelihood of being optimal in the immune modulation domain. The slide shows the Kaplan-Meier plot, and here again, these two lower curves are the tocilizumab and sarilumab curves, and the upper two curves are the anakinra and control curve. The lower the curve, and then the more skewed to the right, the more organ support free days there are for participants in that arm, and so the better it is, and you can see the clear separation there. And then also when you look at the distribution, you can see that overall for toci and sarilumab, there are fewer participants with the worst outcomes and more participants with better outcomes, more organ support-free days. A separate study of immune modulation therapy was the tofacitinib Stop COVID trial. Tofacitinib is a Janus kinase inhibitor or a JAK inhibitor. This was a randomized control trial of tofacitinib given as 10 milligrams orally twice daily or placebo for 14 days or until the time of discharge. This study was conducted in Brazil. The primary outcome was occurrence of death or respiratory failure through day 28. Just under 300 participants were randomized, approximately 90% of whom received corticosteroids either at study entry or sometime during the course of the study. None received remdesivir because remdesivir was not available in Brazil at the time the trial was being done. This study, which was published in the New England Journal of Medicine, demonstrated a significant survival advantage for participants who were randomized to tofacitinib. You can see the reduction here in mortality in this expanded view of the Kaplan-Meier plot. Overall, that was about a 35% reduction in the risk ratio for death, and that reduction was seen similarly in men and women, perhaps a little bit more so in older than in younger participants. Again, there was no real antiviral therapy. These people were only getting oseltamivir, which we know is not active against SARS-CoV-2, and whether they got glucocorticoids or not, and perhaps some benefit for people who were treated, who started treatment a little later than earlier. Lastly, let me turn to some information about ivermectin. These data were published some time ago, but we get so many questions about the use of ivermectin that I thought it was worth sharing. This study was a single-center randomized placebo-controlled trial in patients with symptomatic COVID-19 conducted in Cali, Colombia. Participants had mild disease, which according to their definition meant not receiving high flow oxygen or more intensive respiratory support. Others might consider this moderate disease if people were receiving supplemental oxygen. The primary outcome was time to resolution of symptoms within 21 days of study entry, and the study enrolled 400 participants. As you can see from the Kaplan-Meier curve, there was absolutely no benefit of ivermectin. The hazard ratio here is 1.07, and the p-value is 0.53. There was no advantage in terms of time to resolution of symptoms, the proportion who had symptoms resolved by day 21, nor were there any significant benefits in any of the secondary outcomes as well. And so I think ivermectin really should not be used and has become the hydroxychloroquine of 2021. So in conclusion, treatment of COVID-19 continues to evolve. New clinical trials data are being reported almost weekly, but treatment needs to be guided by the data as they emerge and should be modified and updated as new information becomes available. Thanks for your attention, and I look forward to the discussion period.